Hey there, this is Kristen with a quick content warning before we jump into the episode. We're talking about GLP-1s and their side effects, which includes mention of suicidal ideation. If this is a sensitive topic for you or anyone else listening, please take care. Thank you. This is Health Matters, a podcast from Mayo Clinic where we discuss the latest medical advice, news, and research to help you live a happier and healthier life. My name is Kristen Meinzer. I'm a writer and journalist, and this episode, we're continuing our conversation about GLP-1s 1 year later. If the past year has taught us anything, it's that GLP-1s are here to stay. But as drug supplies fluctuate, insurance coverage shifts, and new data emerges about long-term side effects, the conversation has evolved. We know more about GLP-1s now than ever before, but we also have new questions. About a year ago, I sat down with Tara Schmidt, a registered dietitian with Mayo Clinic in Rochester, Minnesota, and host of another Mayo Clinic podcast on nutrition, to talk about the GLP-1 boom and how it's been changing the weight loss landscape. Now, we're sitting down again to have a second all-new conversation about what we've learned since then, what's changed, and what we still need to find out. Tara Schmidt, welcome back to the show.
Hey, Kristen. Nice to see you again.
Oh my gosh, it's such a thrill to have you back. The conversation we had last year was one of my favorites. It's one of the ones that listeners reach out to me the most often about. And so it's great that we can be back together again and continuing the conversation because we know more now than what we used to know back then. And also the landscape's changed, hasn't it?
It's still a hot topic. I think I have a job for a while if I stay in this field. And we're learning more, but there's also more questions.
So let's talk about some of these changes with GLP-1s over the past year. First off, I know a lot of people know GLP-1s as a weight loss drug, but let's define GLP-1s again.
Absolutely. So in the medical field, welcome to acronyms. So GLP-1 stands for glucagon-like peptide 1, and this is a hormone in the body. So when we talk about GLP-1s or GLP-1 agonists as a medication, this means that these are manufactured substances that cause the same action in the body as the naturally occurring hormone would.
And how do GLP-1s work?
So they work in different organ systems. So in the brain, they are promoting less appetite, so less hunger, more satiety or that feeling of fullness. In the stomach, they are slowing gastric emptying or kind of keeping food in there longer. When they do that, that also decreases the speed at which your glucose or blood sugar rises. In the pancreas, they are stimulating insulin secretion. So again, this is why they started out as diabetes drugs. And in the liver, they're suppressing glucagon secretion. So again, less of that glucose or blood sugar rise.
Can you also quickly sum up your stance on GLP-1s and how you or your fellow practitioners are using them?
High-level GLP-1s are a medication that was once prescribed for diabetes, but is now also FDA-approved for the treatment of obesity. And I use that phrase intentionally because we see obesity as a disease or a disease state. You can use whatever phrasing you want so that people do not feel like this is something that they caused. It is not all in your control. And taking a medication, which would be just like having a surgery if you needed a surgery, is one of the tools that we have for the treatment of said chronic disease. Of course, that's not how we see everyone taking these medications, but from a medical standpoint and from myself as a dietitian, I look at someone who's taking an obesity medication just like I look at someone who's taking an antihypertensive or a blood pressure medication or someone who takes insulin because their pancreas doesn't function well enough to make enough insulin. Now, in all of those scenarios, whether you have high blood pressure or diabetes or obesity, there are still lifestyle changes that I would like you to make and that I'd like you to focus on. And yet, some people still need additional tools in their toolbox to be the healthiest that they can be or to be the lowest risk that they can be.
And last time we spoke, there was a shortage of GLP-1s, which has now officially ended. There is now increased production by major manufacturers, which goes along with a huge growth in demand and increased competition in the market. Prescriptions have skyrocketed, and overall spending on GLP-1s has increased. Has that changed prices or access at all?
Access, yes. And in terms of prices, I believe there are some negotiations going on that may come into effect in 2027, but I'm not privy to that information specifically. And I think it will also likely become harder to access a lot of these kind of off-brand versions of the drug.
Yes, we'll talk about that more in just a minute. But before that, 1 in 8 people in the U.S., or about 12% of the population, have now taken GLP-1s, and about 6% are currently taking a GLP-1 at this moment. That's a higher number than ever before. Are you seeing or hearing more about this increase from your colleagues?
Absolutely. I'm seeing it in members of the Mayo Clinic diet. We're doing some studies in the clinic with patients and members on GLP-1s, and even from friends and family and culture, right? Even socially for people, it's kind of like a gossip topic, like, I'm on it, she's on it, these kind of whispered conversations.
And I have to say, in the circles that I run in, I hear people talking about their own GLP-1 usage, not even with whispers, but just saying it more matter-of-factly in a way that I feel like maybe they didn't feel comfortable talking about it 2 years ago. But let's get back to those off-brand or compounded versions of the drug. Can you remind us of what those are?
So compounded drugs are essentially like a custom-made medication that is available through a specialized pharmacy. Now, sometimes I want to know that we use compounded medications in the medical field. Let's say you have an allergy, but you're allergic to an ingredient in a medication that's very important for you. We may need to go to a compound pharmacy. But in the world of GLP-1s, that's not what we're talking about here. We're talking about when there was a shortage and compounding pharmacies were allowed to make kind of their version of this drug. But they're not FDA approved, and they aren't reviewed by the FDA for things like safety or quality or effectiveness.
And now that GLP-1s are more widely available, the FDA approved versions of them, compounded versions aren't really necessary like they used to be, right?
Yeah, you're right.
Now, despite the fact that folks don't necessarily need to turn to a compounder anymore, there are still compounders out there. Some companies are offering personalized alternatives with different dosages or ingredients. Can you tell us about those?
Yeah, and in all honesty, this isn't something I'm overly familiar with coming from a clinical organization, but we do worry that there aren't clinical studies showing that these are safe or effective. I just have a lot of questions, right? So what are the ingredients they're using? Are they from unregistered manufacturers? Are they meeting FDA safety requirements? So I don't know a lot just because of my career, but I also have a lot of questions that I'm not sure anyone knows the answers to.
So in addition to more people than ever using GLP-1 drugs, there are more advertisements about them, more celebrity endorsements, even a big pop culture movement when Serena Williams became a spokesperson for Ro, which is a telehealth company offering treatment plans for weight loss, including GLP-1s. So what are your thoughts on this pop culture GLP-1 moment? How do you feel about all this?
Like most scenarios, I feel like there are pros and cons, right? So when they first started, my biggest concern with the celebrity culture around it was pretty clear in my mind, and maybe I shouldn't make this assumption, but I was guessing that there were celebrities who were taking these GLP-1s who weren't an appropriate patient for a GLP-1, if you can kind of catch my drift. Like I had a feeling that they wouldn't have actually been approved, let's say. They did not have diagnoses or comorbidities. Now, we cannot judge someone by looking at them, but I just felt like it was a little too widespread for me to assume that those people needed them. And for an example like Serena Williams, there's two sides, right? So the positives being, now we have this amazing woman who is sharing her story. We can say this isn't something we have to be ashamed about talking about. There are some aspects of our health and weight that are not in our control. And weight loss is hard for even like an elite goat of an athlete. And I also give her credit because she did address publicly that she was intentional about her eating and exercise, which I think we all knew about all the time. And then negatively, I think there was some bad press simply because it was a celebrity endorsement of a drug, which is always a little bit on the gray side of things. A question being, is she promoting weight loss injections? Does this reinforce societal beauty standards? Does this tell young girls or even young boys out there that your achievements don't matter if your appearance isn't up to par? Was it in poor taste if there was a shortage at the time? So now we're emphasizing that access and privilege is on the table. So those were the thoughts that had gone through my mind.
Yeah, and regardless of what the medication has been, there's always been a question in a lot of people's minds about, should a celebrity be paid to tell me how to improve my health? And how trustworthy is that? How medically on the up and up is that? So there's also that aspect to it. What kind of impact do you think all of this has had on the public? You know, partnerships like Serena and Roe, or celebrities being forthright or secretive about their GLP-1 usage?
I think that's hard because, again, does it lessen the stigma around obesity? Does it tell people, hey, it's okay, and there are treatments and there are medically approved pathways for weight loss, and or does it further exacerbate our culture of thin equals health, which I don't, of course, agree with.
So let's recap some of what's changed. As of the time we recorded this, there's no longer a GLP-1 shortage. Has that improved access? Yes. Has it affected or will it affect the price? The answer to that is less clear. During the shortage, we saw compounding pharmacies making their own off-brand versions. But now that the FDA-approved versions are widely available, it's unclear if compounding will be able to continue this way, or if there will be a crackdown on unregulated versions of GLP-1s. That part of the story is still evolving. In terms of how GLP-1s are affecting our culture, they're definitely becoming more widespread. Both everyday people and celebrities seem to be more open about their GLP-1 usage. But the relationship between celebrities and GLP-1s is a gray area. Are celebrity endorsements making these treatments more accessible and socially acceptable for the people who need them? Or are they reinforcing the harmful idea that we should all be thin? This past year, we've also had a chance to learn more about the long-term practicality of using GLP-1s, whether it's insurance, side effects, or other difficulties. Let's break down some of those. Let's talk more about these downsides. We know that GLP-1s have a lot of benefits, but what's become more difficult about getting treated with GLP-1s?
I think now that access has improved, I'm hearing more insurance challenges. So insurance coverage, prior authorizations, step therapy requirements, even for the name brand drugs. So kind of what steps do they have to take to get the drug? And even if they do have insurance, and if they have an employer who covers this drug, how much is it? And for how long is it covered? Is there a cap? How much is it out of pocket? My other concern is I also think there continues to be a lack of multidisciplinary care when it comes to treating obesity with these drugs, which is a complex chronic disease. And I'm not sure we're using the drugs as they were meant to be used. Again, with the diet, with the exercise, with the mental health. And not everyone has access to a multidisciplinary team, so I want to be mindful of that. But I'm also not seeing a lot of prescribing entities encouraging it. I think a lot of people can kind of just get the drug and move on. Like you pay for the drug, it comes to your front door, and no one's told you how to eat or how to exercise or what to do if you do have side effects.
Yeah, because GLP-1s should not just be used on their own. They're part of a bigger methodology of health, of wellness, of nutrition, of movement, of mental health. And so we can't just be handing out this drug to folks without giving them the full treatment, right?
And that's how they were used in studies. That's part of the prescribing guidelines. But of course, that doesn't always translate into real life. And I understand that that's not always at the patient's fault, of course.
Something else that is not the patient's fault is what happens when a patient reaches what is considered a quote-unquote healthy weight, and what happens to their access to GLP-1s. Because in some cases, once they reach that number on the scale, some insurance companies say, well, that's that. You don't get any more of this medication. But last time you were on, Tara, you were saying this is a medication people should be taking long term. And so what happens in those cases?
Yeah, this is actually something I'm really interested in. I don't know a ton about it because, of course, this always takes years, right? So we need years of research after people have been on the drug for a long period of time and then they've no longer been on the drug. So a question would always be, okay, yes, they've reached a healthy weight or whatever parameter we're looking at in terms of percent weight loss. But if we stop the drug, we not only risk the regain in weight, but we risk the recurrence of any comorbidities that they were also taking the drug for. And so what's really difficult, I think, to study is the ROI. So we kind of know about the return on investment for something like bariatric surgery. This many years after bariatric surgery, these comorbidities have resolved. This is the decrease in cost of healthcare, et cetera. But with these drugs, I think it's a little bit more murky because they're not a permanent solution, essentially, right? So bariatric surgery is a permanent altering of the gastrointestinal tract, for example. But because drugs aren't a permanent solution, you may take them or stop taking them or have to stop taking them or no longer have coverage. And so I think that because ROI is so difficult to calculate or maybe impossible to calculate, insurance companies or employers aren't really sure what to do.
Another area that's full of uncertainty is the ways GLP-1s can affect people beyond the scale. For example, it might not just be appetites for food that are being suppressed by GLP-1s. It might also be appetites for things like sex. And there have been a number of articles written about this and about the side effects for relationships, for marriages, and so on. And to paraphrase an article in The Cut, the effects on just the outlook on life in general. They wrote an article called Life in Beige, Are GLP-1s Worth a Life Devoid of Pleasure? So I'm curious about your thoughts on all of this from a medical perspective.
So first of all, I always like to discuss with patients, especially who intend or plan to go through major weight loss, that weight loss can really change relationships. Sometimes for the better and sometimes for the worse. So an example would be someone has lost a significant amount of weight and now they are more active with their children and their grandchildren and they're running around the park playing instead of sitting on the bench. That's fabulous. We celebrate that every day. And on the other side, I've also had examples of people and their relationships going more negatively because they lost significant amount of weight. Their confidence increased, but their spouse did not lose weight, and they felt threatened in that relationship or the attention that their spouse was now getting at a different body weight. With GLP-1s, we of course have mixed research. So 2 examples I'm familiar with are on the negative side of things. There was a study done in 2024, which is pretty large, that found that people with obesity who were on GLP-1s had elevated risk of anxiety and suicidal behavior when they compared them with the controls. Another study in 2025 demonstrated that GLP-1s might drive depression and suicidal ideation in people who already were genetically predisposed towards low dopamine. That's kind of the scary research and, of course, what we want to be mindful of. However, on the other hand, we had a 2024 study that found that GLP-1 users who did not have any known mental health diagnoses weren't found to be any more likely to develop depression or suicidal actions. Right now, the FDA, as well as over in Europe, the European Medicines Agency, have both deemed them safe in terms of evidence on suicide for now. But of course, we will continue to look and pay attention.
And for people on GLP-1s who feel any of those negative symptoms, it's really important to be working with your medical team and be honest about what you're feeling so that they can help you.
Absolutely.
Regardless of whether that means lowering your dosage or bringing in other interventions. Do we know why GLP-1s are having that depressive effect on some people?
We think it might be related to dopamine and some of those pleasure centers or craving centers even in the brain. So we know that these drugs not only work in the GI tract and in the pancreas, et cetera, but they're also working in the brain, which is partially positive if we're thinking about using them for something like addiction and decreasing the rate of addiction in our population, which would be very meaningful. But we also may be seeing people who are really sensitive to that decrease in dopamine. And you can think about dopamine kind of as a rise. So if you watch a funny dog video on YouTube, you get a boost of dopamine. If you have sex, you get a boost of dopamine. If you eat a really good, delicious food, you're going to get a boost of dopamine. This is all well and good. But when that's dampened, I think is what's scary. So that's what I think we'll have to continue to be really mindful of. So yes, we should likely have less drive and cravings related to food. But if life's feeling a little bit beige, then I think we should be talking to our medical provider.
That being said, just to play devil's advocate for a second here, isn't that one of the reasons why GLP-1s have been found to be helpful in addiction situations? Because not only are they reducing the noise for whatever substance somebody is addicted to, but it's also reducing the pleasure when they do partake in certain substances, where it's like, oh, I really want alcohol. I really want alcohol. I want alcohol less than I used to want it on a GLP-1, but I still want it. So I'm going to have some alcohol. Oh, no, it's not making me high.
Yeah, exactly. Well, and we can even talk about that in nutrition, like decreased appetite for someone who struggles with overeating and for someone who has class 3 obesity, generally speaking, is not a bad thing, but I still need that person to nourish themselves. So I feel like it's this dial analogy of like, okay, we want to turn down the dial, but how far? Because we also know that there are people on GLP-1s out there who are not eating and who are not drinking. And I'm like, oh, well, that's not great. I don't really care what your weight loss is. And you can also be malnourished in a body with a diagnosis of obesity. So malnourishment doesn't mean thin and cachectic. Malnourishment just means you're not getting enough of the right stuff. So it could be really meaningful and healthful and impactful for some people, but we got to make sure that dial doesn't go all the way down to no pleasure or to no eating.
Now, a new JAMA piece says that 50 to 75% of people who start GLP-1s discontinue use within a year. We already mentioned that maybe some of this is due to insurance coverage ending when somebody reaches a certain weight, but what are some other reasons that people might be stopping their GLP-1 usage within 1 year? Because that's a huge percentage, 50 to 75%.
It is. So the most common reasons we're aware of are cost. So what are they paying, whether they have partial coverage or not? Access, like you mentioned, reaching their goal weight, quote unquote, and also side effects.
And stopping GLP-1s also comes with risks like weight gain, return of cardiovascular risk, and more. So one should work very closely with their medical team when ending GLP-1 usage.
Yeah. Absolutely.
There's no such thing as a miracle cure, and GLP-1s are no exception. One of the biggest challenges we're seeing is that there aren't standard insurance guidelines for how to cover GLP-1s for certain conditions, or for how long, despite the fact that GLP-1s should be taken long-term. We're also learning more about the side effects of GLP-1s. Many people have reported depressive symptoms after taking them, ranging from feeling blah to suicidal ideation. Any level of these symptoms is worth talking to your doctor about. In the past year, we've also seen that at least half of people who take GLP-1s discontinue taking them within a year. There are many factors that could be driving this, but if you want to stop taking GLP-1s, make sure your care team is looped in on that decision. Now, it's time to look into our crystal ball and try to predict the future of GLP-1s. So let's look to the future of GLP-1s. Last year, most GLP-1s were being issued as injectables. Is that still the case, or are there other ways that GLP-1s are being administered now?
So we do have one oral called Rybelsus, which is FDA approved. Now, this is not FDA approved for obesity. At this point in time, again, we go back to diabetes, so approved for glycemic or blood sugar control, also to reduce the risk of major cardiovascular events. And we do know that there is another GLP-1 that will be coming out in an oral form by Eli Lilly in the future. I don't know the date. Coming soon to a pharmacy near you.
When we spoke last year, you mentioned that there are possible new applications for GLP-1s beyond diabetes and weight loss. Let's talk about those.
So because GLP-1s work in so many different ways, I know we talk a lot about weight management, but we not only lower someone's weight, but we increase their insulin, we increase their beta cell function, we decrease their glucagon, we improve their lipids, we likely improve the health of their liver, the health of their heart, kidney disease. So we know and are studying about a lot more conditions that GLP-1s can help. And we don't always know, it's kind of a chicken or an egg thing of, is it the weight loss or is it just the GLP-1 itself and the mechanisms of action? But some examples would be addiction, chronic kidney disease, cardiovascular health is one that's already kind of approved on the list. MASH, which we used to call fatty liver, which is metabolic dysfunction associated steatohepatitis. I prefer to just say MASH. But again, think about all of the different organ systems. So the heart, the liver, the kidneys, and then a really exciting ones in the brain. I mentioned substance abuse, but also neurodegenerative diseases like Alzheimer's. I might have mentioned that last year, but that's one that's obviously still being studied, but could be so meaningful, I think.
Oh my gosh.
Yeah.
Wouldn't that be incredible?
I know, it's kind of goosebumpy.
And then we also talked last time about the possibility of triple agonists. First, can you remind us what double agonists are and how a triple agonist would be different?
Yes. So in this world of GLP-1s, we have single, dual, and triple hormonal agonists. Wegovy would be an example of a single, just GLP-1 receptor agonist. If you think about dual, we've not only got GLP-1, but we also have GIP, which is gastric inhibitory peptide. GLP-1 and GIP are two different hormones secreted after we eat that are playing those roles in glucose metabolism and kind of energy balance. That's Zepbound. Now we can talk about triple agonists. So now we're talking about three hormones: GIP, GLP, and glucagon, sometimes known as GCG. So this triple agonist or triple hormone, like we're talking about, is in development for the treatment of obesity. So as we move from single to dual to triple, targeting more of these hunger regulating hormones.
And when we're targeting triple the number, does that mean it works 3 times as fast or 3 times as well?
Maybe not 3 times, but we do see more and more total body weight % weight loss when we move up the level. So The triple agonist that's being studied right now, and it's not even over yet. They're continuing to see weight loss. They haven't even seen a plateau yet. But in the world of 24% total body weight loss, now we're talking about what people are getting with bariatric surgery. So these are really powerful drugs.
Wow. Right now, Medicare does cover the cost of some GLP-1s when prescribed to treat diabetes or prevent heart attacks or strokes for adults with heart disease, but it's still prohibited from covering drugs prescribed for weight loss. Do we know if that might change in the future?
Maybe is going to be my answer. I think it might change in the future, and especially when we see that these drugs have a greater impact rather than just weight loss. So cardiovascular disease is the perfect example. When we see that these drugs can decrease someone's risk of a cardiovascular event, then I think the important bodies at play start to open their eyes and say, like, okay, this is not just about weight loss. This is life-saving. This is saving money long-term. So I do think that that might change, especially if we start to see the research years out of what else these drugs are doing. I think we'll continue to see that progression as to not only how powerful they are, but maybe all of the different organ systems they may benefit, especially when we talk about going from single to dual and now almost to triple agonists.
In late 2025, the federal government announced 5 deals with major pharmaceutical manufacturers to bring GLP-1 prices for Americans down so that they would match prices in other developed nations. How do you think that might change how we here in America might use GLP-1s?
I'm not sure if it will change how we use them, but I do think it will be significant for people who need their insurance to cover these drugs in order to have access to them and in order to use the FDA-approved versions of them. If you need a drug that your employer doesn't cover or doesn't cover after X number of months or X number of dollars, that's pretty significant. So this could be big for America because we know that other countries are paying significantly less right now.
So much less, yes. Last time we talked, we were mentioning how some people are spending many thousands of dollars a year on GLP-1s. Now, GLP-1s have reshaped not just our bodies, but the economy and changed how we spend money in other industries. A Cornell study found that GLP-1 users' grocery spending has gone down, with people spending less on processed food. There's also increased spending on activewear.
I'm here for it.
We talk a lot about how we have an obesogenic environment, one that encourages us to eat poorly, exercise less, and so on. I know you're not an economist, but in your circles, have people been talking about how much this can change our country in terms of our environment?
I think the one that I'm most informed about is how it's already changing our food environment. So you mentioned decreased spending on ultra-processed foods. That works for me. I'm absolutely game for a decreased consumption of ultra-processed foods, especially those, of course, that are low in nutrients, high in calories, so kind of those empty calories we talk about. I'm also familiar already with the food environment as it does adapting to these trends. So we see trends. We see low carb, we see low sugar. So now we're starting to see, quote, GLP-1 friendly, higher protein, right? Are we going to be seeing more things with fiber? Are we going to see reduced volume items? Are we going to see restaurants adapt their portions at all?
Oh, we have here in New York where I am. There are definitely some restaurants offering more GLP-1 friendly menu items now as far as portion size go. Yes.
Okay, I usually just order off the kids menu. That works for me.
Me too, if they let me.
I know. Or the senior menu. That one works too.
And by any chance, have you or your colleagues seen patients changing their habits along with their GLP-1 usage? Have they said to you, I've been doing this more, I've been doing this less, or I've changed up how I do this?
I think I hear the most impact about food noise and saying like, I'm just not thinking about it all day long. I'm just not driven to overeat. I just don't care as much. And that doesn't mean we have to go into like scary beige, I don't enjoy food as much anymore. It can be very positive of, I still enjoy food, but I am able to consume it in reasonable amounts. I don't overconsume excess empty calories. I prioritize my protein and my fiber, my hydration, because I know that that's what's going to make me feel the best. And I think that that's really relatable.
That's great. In the last year since we talked, have you changed your mind about anything regarding GLP-1s?
Good question. I don't think like my values or my clinical opinion has changed. One thing that I'm moving towards acceptance of, and I want to say this carefully, is provider-driven. I don't even want to use the word microdosing, but I want to say changes in a dose. So when we talk about microdosing, what I'm most hearing about is patients who are getting a compounded medication with a syringe and choosing their own dose or not dosing their medication as it's been prescribed. That is scary. That is not FDA approved. I can't endorse taking a medication other than how it is prescribed, right? So think if we did that with insulin or an antidepressant or your birth control. I get that this is a different example, but again, this is not how they were studied. However, I have learned and been hearing from physicians who I highly respect a little bit more about in the future, we might be learning more and experimenting safely with maintaining people on a lower dose. Like you were mentioning, keeping someone on a medication because they have reached a healthier weight, but maybe they don't need that original or even the lowest dose that we know about right now through the FDA. And so if you would like to consider changing your dose, taking it less often, experimenting with anything other than what's written on the bottle or the box or the vial, I just want you to run it by your prescribing provider so that I can sleep at night.
Any other predictions for what to expect in the future with GLP-1s?
I think we will see some exciting changes moving from injectables to orals and what that does for cost. Because if you think about the injectable medication, it's not only the pen and the actual method of injecting a medication, but it's also keeping it refrigerated and all of the cost that goes with that. I'm excited to learn about how we help people maintain their weight, whether that be on different medications or on lower doses of the same medication. And I'm excited to learn more about the additional benefits that these drugs may have.
And is there anything that you're hoping we learn more about with GLP-1s that we don't know now? Things that maybe are looming questions you have?
We have a feeling or know that there's going to be more benefit, but I do know that a lot of people still have concerns about the longer-term side effects. So if people are taking these drugs, if they're losing significant amounts of weight, when do we stop them from losing weight? Do we see malnutrition? Do we see risks of undereating? Do we see use by people who are at risk of disordered eating or who may have an eating disorder and are using the drug or develop an eating disorder? So the positive, but also kind of the scary of what we don't know.
Wow. Hopefully we'll be sitting down again in another 365 days, Tara.
I love it. Or sooner, but yes.
And we'll have more answers to all of these questions. Tara Schmidt, it has been such a pleasure to talk with you again. Thank you so much.
Thank you, Kristen, for having me on again. It's always a pleasure to talk with you.
As far as we can tell, we're still on the crest of the GLP-1 wave. We might soon see more oral medications hit the market, as well as more and more uses for GLP-1s. Triple agonists are on the horizon, and we're beginning to study how different doses may affect people's ability to stay on these medications long term. And of course, as GLP-1 use increases, these drugs will continue to create ripples throughout our culture and the economy, from what we wear to how much food we buy. But that's as much as we can predict for now. For the rest, we'll just have to wait and see. Okay, that's all for this episode. But if you've got a question, a topic suggestion, or a follow-up question about this episode, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. For more Health Matters episodes and resources, head to mayoclinic.org/Health Matters. And if you found this show helpful, please subscribe and make sure to rate and review us on your podcast app. It really does help others find our show. Thanks for listening, and until next time, take care and stay healthy.